No, that's better. Good evening, everybody. Welcome to our latest session in navigating the medical system. Tonight, we are having our first ICE session in 6 years. Difficult to get an ophthalmologist who really can speak well, and we got one. Dr. Siri Shetty is a member of the NYP staff. He went to the Medical College of Georgia, trained with ophthalmology in Washington at Georgetown University, took a fellowship at Weill Cornell, and now is on the staff. He's an assistant professor of ophthalmology. He has asked that we ask our questions after the talk is over. So let him talk through and raise your hands at the end of the lecture. And if you want to write a question down, I'll try to get something. Sorry, Linda's not here tonight to give out pads and pens, but yeah, we'll try to get something to write on. Dr. Shetty.
Thank you. Okay, so as Dr. Bright said, my name is Dr. Shetty, and I work over at the New York Presbyterian Queens Eye Center. We're located at 17415 Horace Harding Expressway. And today I'm going to be talking about glaucoma as well as other common age-related eye disorders. So first let's just talk about the different parts of the eye. So I have a couple pictures here. This is just a picture of the front of the eye. And here you can see, of course, the upper and lower eyelids. The colored part of the eye here is known as the iris. Right in the middle here is the pupil, which is the opening of the iris. The white part of the eye we call the sclera. And then overlying the white part of the eye and also the inside of the eyelids is a clear, thin membrane that we call the conjunctiva. Now, if you look at the picture on the left here, you can see this is the eyeball with the front of the eyeball on this side and the back of the eye on that side. And you can see this clear layer here is called the cornea. That's sort of a clear dome-shaped covering of the eye. Behind it, again, the colored part of the eye, and behind that is the lens. And we're going to focus on this a little bit when we talk about cataracts. Then at the back part of the eye, I'm just going to step across here. At the back part of the eye here, lining the inside, that's where you're going to find the retina. And we're going to talk about that when we talk about macular degeneration. And that involves the central part of the retina here, which we call the macula. And the very center here is called the fovea. I know these words are a little hard to read. And then this structure here is what we call the optic nerve. What that does is it connects the eyeball to the brain. And we're going to talk about that a little bit when we talk about glaucoma. So these are sort of the basic parts of the eye. And some people always ask, what fills up the middle of the eye? So all this empty space here is filled with a gel that we call the vitreous humor. And when you see floaters floating around, usually they're caused by changes in this gel in the middle of the eye. So, as I mentioned, we're going to focus on three main conditions today. Number 1, glaucoma. Number 2, cataracts. And number 3, macular degeneration. You may see the full name, age-related macular degeneration. Sometimes we just call it AMD or ARMD for short. So, what is glaucoma? Glaucoma is basically a condition where the pressure inside of the eye causes damage to the optic nerve, which then leads to a slow, progressive loss of your peripheral vision. And the peripheral vision is your vision when you're looking straight ahead, what you see out to the sides, up and down below. That's your peripheral vision. And it's usually associated with high eye pressure, although glaucoma can even develop in what we would normally consider the normal range of pressures. Normally your eye pressure should be between 10 and 21. So anything above 21 we in general consider abnormal. The important thing to know about glaucoma is that any vision you lose from glaucoma, unfortunately, is permanent. And we don't have any way to sort of get that vision back. So, all the treatment is aimed at sort of preventing further vision loss. And so that's why early detection and early treatment is sort of key to preventing that significant vision loss. And so if you want to imagine what glaucoma, people with glaucoma experience, here's a little picture here. So as you can see on the left side there, that's sort of a normal picture, what you might see if you don't have glaucoma. When you start to develop early glaucoma, you just start to lose sort of the very edges of your field of vision. And as it gets more severe, you start to lose even more of that outer part of your vision. And so what happens if you want to know what people with glaucoma experience, if you just sort of put your fingers like that and look like that, that's essentially what they experience. It's sort of tunnel vision. Okay, their visual field slowly gets smaller and smaller. And eventually, unfortunately, in some people who have very uncontrolled glaucoma, they could even lose the vision completely. So the goal is trying to prevent that. So glaucoma, there's many different types of glaucoma, I should mention. The most common type is what we call primary open-angle glaucoma. And that occurs very slowly over the course of several years. There are some types, however, that can occur very suddenly. One main type that some of you may have heard of is called angle closure glaucoma. But the most common type affects about 2.2 million Americans, and they project by 2020 it'll affect about 3.3 million Americans. And there's many risk factors for developing, one of the types of glaucoma, all of the types of glaucoma. So number one is, older age. So the older we get, the more risk we have of developing glaucoma. There's certain races also, African Americans, Asians, Latinos, the Inuits, that are at higher risk for developing one type of glaucoma or another. Also, if anyone in your family has glaucoma, that increases your risk of developing it. So it's good to ask, because sometimes people don't talk about it, and you never know until you sort of ask around. If you have diabetes and it's poorly controlled, if you've ever had an injury to the eye, or even certain types of eye surgery, or conditions that cause a lot of inflammation in the eye, all these things can kind of increase your risk for developing certain types of glaucoma. So the thing about glaucoma, as I mentioned, typically it occurs very slowly. And so often people that have glaucoma don't even realize it. And it's because if you get a slow tunneling of your vision, you just don't really realize it, because it's not suddenly that your visual field goes away, but it's just occurring so slowly. So often they don't realize it until it's very advanced. However, some things you might notice is that you don't see quite as well as you used to. So for example, some people say that I don't see people coming up from the sides anymore, or I'm driving and I can't see cars out to the side anymore, or I just start bumping into things on the floor that I should be able to see. Sometimes it can be blurry vision, but that's usually more with the acute glaucoma, the one that occurs very fast. Or if it's very, very severe glaucoma, to where it does start to affect even the central vision, that your vision can become blurry from the glaucoma. As I mentioned, there is a type that we call angle closure glaucoma, and that type is a little bit different. It can present very suddenly, and you may get eye pain, eye redness, blurry vision, headache, stomach ache even, light sensitivity, tearing. This kind is usually an emergency, and most people that develop this kind either go to the emergency room or to an eye doctor's office immediately, because when it presents like that, it's very, very severe, and so you would know if that was happening. And, how do we diagnose glaucoma? So it involves not just one thing, but sort of a combination of different tests. So of course the eye exam is important. Checking eye pressure, doing a peripheral visual field test, doing scans, pictures of the optic nerves. And, we can't just diagnose it with one thing alone. So often the first time you come in, we may say, you know what, there's a little bit of suspicion for glaucoma, or you fall into this category that we call glaucoma suspect or borderline, or your eye pressure is a little bit high, and that'll prompt us to do these other tests. And then when we sort of look at the combination of tests, then we can say, you know what, it looks like you're developing glaucoma, you're at risk for glaucoma, or you have glaucoma. And we can even sort of grade the severity based on these tests. And also it's important to notice that, to note that these tests periodically need to be repeated to monitor your progression, to make sure that, is the glaucoma getting worse? Is it staying the same? As I mentioned earlier, usually it does not get better, with the exception of that acute glaucoma, which can actually get better. So treatment, as I mentioned earlier, it's mainly aimed to lower the eye pressure and therefore try to slow down the glaucoma or stop it from getting any worse. All forms of treatment, whether it's eye drops, laser, surgery, everything pretty much is aimed at lowering the eye pressure. And so typically we'll start with prescription eye drops, which can do just that, lower the eye pressure. And there's many different eye drops out there. Some people need to be on a combination of different eye drops to try to lower the eye pressure enough. In some cases, certain pills may be necessary to get the eye pressure down, but usually those pills have side effects and can affect other medications, so those we use in limited cases. If that's not enough, there are certain laser treatments or even surgery that can be done to help lower the eye pressure. And there's different types of laser treatments for glaucoma. There's also many other different types of laser treatments that we use for other eye conditions. So it's important to just understand that when somebody says laser, it's not necessarily LASIK surgery. There's many different lasers that we use for the eyes. And some of those laser treatments can be used early on in that glaucoma process, and we'll talk about a couple in a minute. And again, I just want to reiterate that treating glaucoma will not improve your vision, okay? So the main thing is to prevent you from losing any more vision. So again, the key is detecting it early, treating it early, and preventing further vision loss. So let's talk about the laser procedures. So some of you may have had one of these done or know someone who's had this done. So the first we'll talk about is what we call a laser peripheral iridotomy. For short, sometimes we say LPI. What it means is that basically, we use this on patients who have what we say narrow angles or angle closure. When we're referring to that angle, we're talking about the space between the cornea, that clear dome-shaped part in the front of the eye, and the iris, which is the colored part of the eye right behind it. So if that space is very narrow, it puts you at risk to develop angle closure. If that space is all the way closed, then that's what we define as angle closure, essentially. So this procedure, what we can do is sort of make a little hole right in the colored part of the eye, and you can see it in the picture here. This is a little hole that was made with the laser. And what that hole does is it helps to reduce that angle from closing all the way down and preventing the fluid from draining out of the eye. And it prevents that sudden increase in the pressure associated with angle closure. So it can cure angle closure or reduce the risk of developing angle closure. So as I mentioned, angle closure is a little bit different than that common type of glaucoma, the primary open angle glaucoma. So this type can actually potentially be cured or prevented. It is usually done in the ophthalmologist's office. It usually is a fairly quick procedure. You don't need any kind of systemic or general anesthesia or anything like that. Usually just eye drops to numb the eye, and then we use a special lens and a laser in the office to do this procedure. There's another type of laser, which we call laser trabeculoplasty. What this type of laser does is it doesn't make any hole or opening or anything like that, but what we do is we apply it to the area where the fluid gets drained out of the eye. We call that the trabecular meshwork. That's where the fluid naturally inside of the eye gets drained out of the eye. And this laser helps that outflow of the fluid, so it just helps your eye to drain the fluid a little bit better. What it does is helps lower the eye pressure, and in some cases we do it early on in the process. In some cases people can get this laser procedure done, it lowers the eye pressure enough, and then you may not need to use any eye drops. But often you still need to use the eye drops, but you have sort of an extra thing helping lower the eye pressure and control the glaucoma. And these are fairly safe procedures with low side effect profile, so it's good if you need it. Now, actual glaucoma surgery, this we usually use as sort of a last resort. I don't want to say necessarily last resort, but we use it, if the other things are not working. And the reason is because there's more risk involved with glaucoma surgery. There's many different surgical options, but again, all of these surgeries are aimed at, again, helping that fluid inside the eye get drained outside of the eye. And when I talk about the fluid in the eye, I'm not referring to your tears. The actual eyeball itself is actually filled with a gel in the back part and sort of fluid in the front part. And your eye is constantly making that fluid and constantly draining it out. So you can imagine if the fluid is not draining out properly, that pressure sort of builds up, and that's why the eye pressure goes high. And so these surgeries are aimed at helping that fluid drain out of the eye. And some of those involve a little drainage device. You can see in this picture here, it's showing a little metal tube there, and it's going into that space right in front of the colored part of the eye, behind the cornea, helping fluid drain out of there and out of the eye. There's another device, which is a different type of, we call it a valve, basically, with a tube, and that tube, again, drains the fluid out, and it comes out of this valve on top of the white part of the eye, and gets drained out naturally through what we call our lymphatic system, but it just naturally gets drained out of the eye, essentially, once it's outside of the eye. And all these things just try to lower the eye pressure. There's many types of surgeries I mentioned. These are just a couple options. When you see, your glaucoma doctor, they'll talk to you about, if you are at that point where you need surgery, which type of surgery might be best for you. It's important to note, again, that, sometimes the surgery works well enough to where you don't need to use eye drops anymore, but that's not a guarantee. So some people, even after surgery, still are using eye drops to help control the pressure. And then again, I want to reiterate that if you're only getting glaucoma surgery, likely your vision is not going to improve at all. However, if it's combined with another surgery, such as cataract surgery, sometimes your vision can improve a little bit. Even though the glaucoma is not improving, the cataract part would be improving. And we'll talk about the cataract a little more right now, actually. So that was glaucoma, which affects, again, the optic nerve in the back of the eye. Now we're going to shift gears towards the front of the eye and talk about cataracts, which affect the lens inside of the eye. So I mentioned in the beginning that the lens is right behind the colored part of the eye, and the lens helps to focus light onto the back of the eye, the retina, so we can see properly. So a cataract just means that the lens inside the eye has now become cloudy. It's not clear like it was when you were born. This is the leading cause of preventative blindness in the world. There's a lot of people out there in different countries, especially, who don't have access to any eye doctors close by, and they, just think that it's due to old age, that they're just blind, and this is just how they have to live, when it's something that nowadays we have a very good treatment for, which is cataract surgery, which we can essentially completely cure cataracts by removing them. It affects about 20.5 million Americans over the age of 40 years old, so about 1 in 6 people in the older, above 40 years old category have a cataract. And the truth is that really every one of us will develop a cataract if we live long enough, so it's not anything to be too shocked or too scared about. As I mentioned, we do have good treatment for it, so in a way you can think about it being a good thing that you've lived long enough to develop a cataract, so don't be worried about it too much. The good news is that, although we all get it, it's almost never an emergency, okay? Not all cataracts need to be treated. On the flip side, though, if you don't treat it, it's not going to improve on its own, and usually it gradually gets worse, okay? In some cases, it may not get that much worse over time, and you may never need to give it treated, but in most cases, most people end up wanting to get it treated at some point. And so, how do you notice if you have a cataract? Well, these are the types of, this type of condition will cause you to have blurry vision. Some people say that when they're driving, headlights and street lights cause a lot of glare, or just any kind of bright lights in the eyes, even sunlight, or bright fluorescent lights, or any kind of lights in the eyes cause glare, halos. It just makes the vision a lot worse. Some people even get double vision from the cataract. And then other people say, you know what, I just got checked for glasses, my vision was pretty good with the glasses, then 2 months later, my prescription changed again. Another 2 months later, my prescription changed again. So it can cause, as it's starting to grow, sometimes it can cause this rapid change in your glasses. And again, because the cataract is there, the glasses can still make your vision better, but it won't, fix the vision all the way back to 20/20 necessarily, because the cataract, of course, is inside the eye. It's sort of like looking through a dirty pair of glasses. That's what the cataract will do to you. Usually the cataracts do not cause pain, they don't cause watering in the eyes, they don't cause flashing lights or floating spots, and they also don't really change throughout the day. So if you're experiencing, my vision's blurry in the morning, but later in the day it's okay, that's usually not from the cataract. If you say, my eyes water, they feel tired, they hurt, they're burning, stinging, none of those things are from cataracts, okay? That's usually more dry eye or something else going on. The cataracts just make your vision, sort of blurry all the time. And then slowly over time, they may get worse. But they don't sort of get better, get worse, get better, get worse throughout the day. So there's, again, similar to glaucoma, for cataracts, there's many different types of cataracts, okay? The most common types that we see, one is we call it nuclear. It's sort of this yellowing and cloudiness that forms right in the middle of the lens. This is the most common type of cataract. There's another type we call cortical, and you can see these little, kind of like, almost like little wheel spokes coming in. That's in sort of the outer part of the lens, the cloudiness in that outer part. Now this one, I know it's a little hard to tell what's going on in this picture here, but what it's trying to show is this cloudiness here, which is on the back surface of the lens. That we call a posterior subcapsular cataract, and that type can be associated with, if you ever had radiation done around the eyes or the face, if you use steroids for any kind of other conditions in the body, if you've had injuries, sometimes that type can occur. So certain things can make that type more common, certain medical disorders. These cataracts, you know, they can occur in combination too. So some people can have all different areas of the lens that are cloudy. So it's not just that you can only have one type, you may have multiple types, okay? Treatment is basically, you know, it's only necessary if the cataracts are causing you problems, okay? And what does that mean? So for one person, they may say, I'm having trouble driving. I don't feel comfortable driving anymore because every time the headlights hit me, I can't see anymore. So now I can't drive at night, and I really need to. Other people may say, you know what, I can't see the TV anymore. It's just not clear. Even with my new glasses, I just can't see well enough. So whatever it is that you do on a daily basis, if your vision is not good enough to see that and it's caused by the cataract, that's the time to think about cataract surgery, okay? Unfortunately, at this point, we don't have any eye drops or medicines or anything that we know of to make the cataract go away. The treatment as of right now is surgery. And I say as of right now because there is research being done to see is there any other thing we can do to prevent cataracts or to stop cataracts without having surgery. And there was, I think just a couple years ago, an article came out saying that there was a medicine that they were doing animal trials on that when injected into the eye, it could help reverse cataracts. But who knows how long it is before that's actually in some kind of formulation that we can use to help prevent cataracts. So as of right now, treatment is surgery. What we do is we basically remove the cataract out of the eye, and then we have to replace it with an artificial lens implant. So some people ask, oh, the cataract, you just scrape it out and that's it. So it's a little bit different. The whole lens now has become cloudy, or parts of it have become cloudy. So what we need to do is remove the entire lens out of the eye and then put in an artificial lens. And I'll show you guys a couple examples of that in a moment. Surgery usually is, we'll use sort of a combination of ultrasound and a little vacuum, and that's what this picture is trying to show here. Again, this is the front of the eye with the clear membrane, the cornea, the color part of the eye there. And behind it is this lens, and you can see this device is sort of eating up the cataract, okay? So we sort of use this device to sort of eat up the cataract and remove it from the eye. There are certain lasers which can be used to sort of aid in the surgery or to do parts of the surgery, but surgery is still necessary to actually remove the cataract out of the eye, no matter which way you get it done.
Doesn't make it flap anymore to pull the lens out and slide in the new lens like they used to. This is a new technique.
So it's a little bit different, yeah. So several years ago we used to do what we used to make a big incision basically, and then sort of pull out the lens in one piece and then put a lot of stitches. So we don't do it that way anymore actually. So now we use very small incisions, usually just a couple millimeters, which this thing can fit through a very small incision. We just break it up, remove it, and then slide the new lens right through that very small incision. So usually you don't need stitches anymore after surgery.
Thank you.
That's a good question. So about surgery, so it's usually done in some type of operating room setting, whether it's a hospital or a surgery center, but it's usually not done in just the office. It typically takes anywhere between, let's say 10 minutes to 45 minutes, somewhere in that time range, so fairly quick. You don't need to stay in the hospital when you get surgery done. You don't need general anesthesia. Usually we just use, a little bit of local anesthesia and numb the eye. Typically we'll operate on one eye at a time and allow that eye to heal, then do the other eye. And you have to use eye drops for a few weeks to help the eye heal and to help prevent infection and recover from the eye. So the overall process is, pretty... When it comes, if you compare it to other surgeries at least, it's, pretty comfortable, and some people even say they enjoyed the experience, so it is possible when you think about surgery.
The most common thing for the second eye done to take a lot longer to heal than the first eye took. What's the reason for that?
So it depends, actually. That's not always necessarily true. It depends on really the aspects of the cataract, how long the surgery takes, different things. So one eye may heal faster than the other, but not always necessarily the first eye than the second eye. It really depends, actually.
Do they tend to do the better eye first in order to...
So typically, most of us prefer, and my preference is to actually do the worse eye first.
Worse
Yeah, allow that one to heal, make sure everything heals nicely before you go to the good eye. Because God forbid something happens in the good eye, if something's going to happen, I'd rather it happen in the bad eye than the good eye. It also helps because what we do is with those lenses, which I'm going to talk about right now, is these lenses that we put in, which you can see pictures of right here. These are just different types of them. These are what the artificial intraocular lens implants look like. There's many different types of these as well, but these are sort of some of the common ones. What it does is it replaces your natural lens, because again, we're removing the lens. If we were not to replace it, then everything would just be out of focus after surgery, so we put in an artificial lens. And this lens, by the way, it's not a contact lens. It actually goes inside of the eye, behind the color part of the eye, and so you won't see it, you won't feel it, you won't know it's there, it just helps you see better.
What is it made of?
So typically it's made of acrylic, but there's other types of material, polymethyl methacrylate and silicone and other things. But the most common material we use for these lenses, the most common lens that we use is made of acrylic. And so the nice thing about acrylic and some of these other materials is that they're foldable, and they're sort of a clear, plasticky kind of material. They can correct, as I was just about to mention, they can correct nearsightedness, farsightedness, astigmatism, all kinds of things. There's even options to try to correct both your distance and your reading vision. There's certain lenses that may do that, but not everyone's a good candidate for that, so that's something you sort of discuss with your surgeon for the different options for that. But the nice thing about these lenses are they can fit, again, through these very small incisions, so we don't need to make a very big incision. Often we don't need to use stitches in most cases. And people always ask, how long will these lenses last? So as long as there's no problem and no complication, and 99.9% of the people, these lenses last a lifetime, okay? And I say that because if it is causing a problem, if it moves, if it causes inflammation or anything, if there's a problem, then it may need to be removed or exchanged. But in general, the lenses will last much longer than you and I will. Alright, so now we're going to move on to our last topic, which is macular degeneration. So macular degeneration affects, again, that retina. And again, I'll show you on the picture here, this is the eyeball, this is the front of the eyeball, this is the inside of the back of the eyeball. So this part, this whole little layer with all these little blood vessels that you can see is what we call the retina. And right in the middle is what we call the macula. It's just the central part of the retina. And here again is sort of a picture when we look inside the eyes, when your eyes are dilated, that's sort of the picture we see. You can see here is the central retina, what we call the macula. And right here is the optic nerve coming into the eyeball, and so it looks sort of like that. And you can see the blood vessels again coming out and into the retina. But macular degeneration, what it is it's a condition that involves basically damage to that central part of the retina, to the macula. And it's the leading cause of severe vision loss in Americans over the age of 50. So cataracts are the leading cause of preventable blindness. Macular degeneration is the leading cause of severe vision loss in Americans over the age of 50. There's two main types of macular degeneration. One is the dry type, the other is the wet type. The dry type, usually there's more scarring and there's sort of damage to the cells in the retina, whereas the wet type involves these abnormal blood vessels that grow underneath the retina. They start to leak fluid and bleed fluid and cause swelling in the retina and fluid buildup, and that causes blurry vision, basically. And sometimes the dry type can turn into the wet type, and sometimes the wet type, basically that those blood vessels and everything get better, they resolve, or they're treated and they go away, and then it doesn't really turn back into the dry type, but essentially we may say, you're sort of in the dry stage. But in general, the wet type tends to be worse than the dry type. About 15 million North Americans currently have the dry type of macular degeneration, and about 1.7 million have the wet type. And there's many different risk factors for this, and so that includes, again, as we get older, this becomes more common. Women tend to get it more than men. This one affects Caucasians more so than people with more pigmentation. And if anyone in your family has macular degeneration, it's something that you want to get checked out for. Smoking, obesity, and any cardiovascular disease risk factors like high blood pressure, bad cholesterol, all these things have been shown to increase your risk of macular degeneration. So people always ask, what can I do to prevent this? So for macular degeneration, don't smoke and try to stay healthy. Okay, and that might help you prevent developing it. So what are the symptoms of macular degeneration? So it's a little bit different than glaucoma, because it can cause blurry vision, sort of like a cataract does. But different from the other two conditions, sometimes it can cause blind spots right in the center of your vision. So if this is the picture, remember glaucoma affected the outer part of your vision, whereas macular degeneration affects often right in the middle of your vision. Sometimes the vision can suddenly get worse, especially in that wet type. And then the other thing it can do is cause this distortion in the vision. So not just that it's blurry, but you may notice, like you can see on this picture here, if you can notice that, here's sort of a normal house, you can see all the lines appear to be straight, and here everything's a little bit more wavy, okay? So it can cause this sort of waviness to your vision, where you can see things, but everything's just sort of a little bit distorted and wavy. So AMD is treated a little bit differently. Unfortunately, the dry type, as I mentioned, it involves usually scarring and sort of damage to the cells in the retina. We don't have really any way to treat that to make it better, but there are vitamins that can be used it has a specific set of ingredients in them which have been studied, and they've been shown to help prevent that dry type from becoming more severe and to help prevent it from becoming the wet type. And so these vitamins we'll sometimes recommend in people who we see early macular degeneration to help prevent it from becoming worse. Now if it becomes a wet type, or for people who have the wet type, this can be treated, okay? And typically that treatment involves injections of medicine directly into the eye, as scary as that sounds. But this tries to help reduce those abnormal blood vessels from growing, from leaking, from bleeding. You can see a picture here, it's a little fuzzy, but this is actually a needle going into the eye and actually, injecting this medicine into the middle of the eyeball. And the reason we do that is because the medicine acts directly where it's needed, right on top of the retina, and also it helps prevent, having side effects because the medicine stays right in the eye and you're not giving it to the whole body. So it works right where it's needed, helps prevent, it spreading elsewhere in the body, and it's actually very effective. There are different medicines that we can use for those injections. The good news is that they are effective. The downside is that they don't last very long. And so some people need injections every 1, 2, 3 months, and sometimes even for several years. So some people have been getting these injections over and over and over and over again. And they come to the office, if you have it in both eyes, you may be coming to the office every couple weeks even, or every few weeks getting one eye done, then the other, then the other, and so forth. So it is something that, we're looking for better modes of treatment. Very rarely do we use certain types of lasers for macular degeneration. Really, the injections are sort of our best way to treat it at this point. So, people always say, well, how do I know if I have this? What should I do? So if you have any of those symptoms that I mentioned and you haven't had your eyes checked out, you should definitely get your eyes checked out. If you haven't had your eyes checked in several years, it's probably a good idea to get your eyes checked out. And if you've been told you have any of those conditions, of course, you want to see an ophthalmologist to make sure that you're being evaluated, treated, if necessary. And the other thing is, some people say, oh, my eyes are fine, I don't have any problems. It's still recommended to get an eye exam. Not if, maybe for people who are very young, they may not need it. But as we get older, like I said, a lot of these things are common, and you may not realize that you're having these things develop in the earlier stages. So definitely get your eyes checked. This is just, there's myself and we have 2 other ophthalmologists over at the Queen's Eye Center. And I specialize mainly, I do comprehensive ophthalmology, but also specialize in corneal diseases and cataracts. We have a glaucoma specialist with us, Dr. Cole, and then also a retina specialist, Dr. Lee. So if you guys don't have anyone or are looking, we're happy to see you. Any questions? Yes.
I have a question about, you should go to the eye doctor.
Yes.
My problem with the eye doctor is the drops. I'm a little, because if I go there, I kind of have to get everybody home.
Right.
And if I can't drive, then I got a problem.
Yeah. So, when you come see us in the office, not necessarily every visit, but sometimes on the first visit or at some visit, we do what we call dilation. What that means is we put in eye drops which make the pupils really big. The reason we do that is so we can see inside the back of the eye a little bit better. The downside of the dilation, as you just alluded to, was basically that it does make your vision a little bit blurry for a few hours, sometimes 4 to 6 hours, and that can affect your ability to see. Most people can see just fine to get around, but driving, or if you have to go a far distance, that might be a little bit, you may not feel safe doing that. So if you can bring someone with you, that's sort of the best thing, to have somebody there to drive you home, or take the bus or something, or the subway, depending on where you are.
Why does glaucoma develop with age, and is that related to the inability of the trabecular mesh to work as effectively as before?
So yes, actually. So the trabecular meshwork, as I mentioned earlier, that's that area where the fluid inside of the eye gets drained out of the eye. So over the years, many things happen. For one, all of our cells degenerate to some extent. And the optic nerve is sort of an extension of the brain and the spinal cord, and unfortunately those cells have no way to regenerate. So over the years, already we know that the optic nerve, what we call the retinal nerve fiber layer, gets thinner and thinner. So just by getting older, we're already sustaining some amount of, loss of cells, I guess, to some extent, or thinning of our nerve fiber layer. Also, our trabecular meshwork, likely, as we get older, may not work as well as it did before
What's happened?
you're younger.
What's happened to it as you get older?
So I don't know why it doesn't work as well, to tell you the truth, but we just know that it doesn't work as well as it should over time. But I can't tell you the exact science behind it. I'm not sure.
SLT would only work for about a year, I guess.
So SLT is that laser trabeculoplasty that I was mentioning earlier. So that's sort of a laser procedure that can be done to help the trabecular meshwork work a little better, to help the fluid drain out a little better. And we found that if it's repeated after a year, sometimes that can help lower the eye pressure even more. And it's something that we know is repeatable.
A couple of times.
A couple times, exactly, a few times. So it's not that it necessarily only lasted a year, but we know that if it's repeated, it can help even more. Yes?
Okay, about glaucoma. Is smoking a risk factor for glaucoma?
So for glaucoma, not necessarily. So they've done all these large studies looking at different risk factors. They looked at diabetes, smoking, other things, and there's not definitive evidence that smoking is bad for glaucoma. However, it is bad for the eyes for other reasons. So you definitely shouldn't smoke anyway if there aren't enough reasons, for heart
How
health.
about,
and
could it be
everything
like a side effect from other medicines?
Glaucoma?
Yeah.
So it can be, yeah. So as I mentioned, steroids are sort of the big one. Steroids cause, or can cause, the eye pressure to go up. And so for some people, they need to be on steroids for, different types of autoimmune conditions or inflammatory conditions in the body. So you just have to be careful, make sure you get your eyes checked to make sure it's not, you're not one of the people that have that problem.
Okay, if someone has glaucoma, they're not taking the drops, if it's untreated, can it lead to total blindness?
It can, yeah, absolutely.
Yes, a family member had surgery for a macular hole, for a macular hole. The surgery went well, doctor said everything's fine, but it wasn't fine because after the surgery, for a few months, the patient still was not able to see clearly, as you said, like we saw a distortion in his vision.
Yeah.
So we're just wondering, none of the doctors will tell us exactly why that was, because according to what they saw, it was repaired,
Looks good.
and it should be seen.
Yeah, so macular hole, I didn't talk about that condition, that's different than macular degeneration, but it involves, again, that central part of the retina, and essentially a hole develops right in the middle. Unfortunately, even when that's repaired and the retina regenerates and our scans and everything show that it looks like it's closed, unfortunately, most often the vision doesn't return all the way back to normal. Most people do have a little bit of distortion, a little bit of blurriness, and that just depends on how people heal. So we can sort of fix the retina and get it to look somewhat normal, but usually the vision doesn't go all the way back to normal. And in some people they get it almost back to normal, but some people it's still pretty blurry and pretty distorted. So it really just depends on how people heal. And giving it time sometimes can improve it depending on how recently they had the surgery done. But after several months or so, if it's still off a little bit, then that's probably what they're going to be left with.
Surgery was done?
Yeah, no. Yeah, as long as it's closed and the hole looks like it's closed, and you can look at that on the scans and everything, then it's really just a matter of healing.
How do you prevent another hole from, how do you prevent further?
So it's tough. I mean, usually what causes the hole is that gel in the middle of the eye, what we call the vitreous, sort of tugging on the retina right there, and it sort of tugs it and causes a little hole to form. Once it's done, it's done. So to prevent it again, there's not much you can really do. If it reopens, it reopens, and just, surgery.
Yeah, there used to be such a thing as you had the time to change of a cataract. You waited too long, it was not going to be good. Is that still a factor?
So to some extent, yes. Different people have different philosophies about it. You don't want to do it too late, and the reason for that is that if you wait too long, and how long is too long is variable, but If you wait too long and the cataract, over time it grows and it becomes more dense, and then it just becomes harder to remove, so the risk of complications goes up. So you don't want to wait too long.
Does that have anything to do with something called a brown cataract?
So the more, I showed you sort of that example where it starts to become a little bit yellow. So in some cases it gets really yellow and starts to become more brown and what we call brunescent. And it gets to almost be, extremely hard. And so those machines we use to remove it, have a lot of trouble removing it. The surgery takes longer. We have to use more sort of energy in the eye, so it takes longer to heal. So just the risk of complications goes up if it's if you wait too long. Now, the reason we don't do it too early is because, as I mentioned, everybody starts to develop a cataract at some point. So I could look in your eyes and tell you, hey, you got a cataract, but you could say, you know what, my vision's fine. I don't have any problems whatsoever. So then what's the point in doing surgery, right? If you're not going to have really much of an improvement, then you don't need the surgery because you are undergoing a little bit of risk. The surgery's safe and the risk is low, but why undergo the risk if you're really not having any problems? So that's why you kind of wait till it's causing problems, and we kind of look at it and we say, all right, the cataract is the reason for your problems. Now it's time to think about surgery. Yes.
Are cataracts beneficial to the eyes, or is that just an old wives' tale?
Are cataracts beneficial?
Carrots.
Oh, carrots. So a lot of things have been shown to be helpful. So carrots are one, but more so leafy green vegetables, things high in antioxidants like lutein and zeaxanthin are good. Omega-3 fatty acids are good for the surface of the eye, for sort of your oil glands working better and keeping the eyes lubricated. So there's a lot of different things that actually have been shown to be good. So yes, they are good actually. Yes.
What would cause blurriness, like after reading for about an hour? Is it the eyes get tired?
Yeah, so I was just speaking with somebody about this earlier. Nowadays we spend a lot of our time looking at the computer, looking at our phones, at tablets, books, other things. I guess books have always been an issue, but the more we sort of stare at things, no matter what it is, we're so focused that our eyes blink about half as much as they're supposed to. When our eyes don't blink, our eyes stay open, and if you've ever tried to keep your eyes open for more than 20, 30 seconds, you notice that it's uncomfortable. So what's happening is that your eyes are just drying out. When they dry out, you can feel all kinds of different things. So sometimes burning, stinging, aching, they just feel tired or heavy. Sometimes you feel like there's something in your eye. Sometimes they even water a lot. And the reason for that is that your tear glands overreact to the dryness, produce too many tears. Also, you may notice your vision gets a little bit blurry or double, and you have to blink a lot to refocus. So the longer we're reading or at the computer or that focus on things, the more our eyes dry out, the more we have these issues. So they will feel tired and strained.
What do you do for that?
So a couple things. So number one, you can use lubricating eye drops, just over-the-counter lubricant eye drops. Number two is every 20 minutes or so of doing those activities, try to take a short break, if even just 20 seconds. And we sort of say the 20-20-20 rule, which is every 20 minutes take a break for 20 seconds and look at something 20 feet away. Just meaning that you're not staring at something, you're sort of just taking a break and either closing your eyes or looking at something off in the distance to where your blinking will return back to normal. And then the last thing is just try to consciously sort of blink more.
You say the complications with cataracts are rare, but if they are, what is the typical complication?
So there's many different complications that are possible. The most serious things are that you could potentially lose vision in the eye. That can happen from things like a very bad infection in the eye or a very bad bleed behind the retina. These things are extremely rare, okay? But more common complications could be your eye pressure goes up a little bit or even down a little bit after surgery. There can be prolonged inflammation after surgery, meaning you need to be on the eye drops longer than usual. Dryness, like dry eye, is a very common complication after cataract surgery. Those things are much more common, but can be treated. Again, in the sort of more rare category would be things like needing further surgery to be done. If a piece of the lens falls into the back part of the eye, that often cannot be removed at the time of cataract surgery and would require second surgery. But the more common things are the things that we can treat.
With glaucoma, is there anything in the works for when you take the eye drops to have it in the eye, like some type of device people who have to take 3 to 4 drops.
Right, every day.
A day.
So actually, yeah, we were just speaking about this earlier, that, it's very tough, right? Because you have glaucoma, you can't see, and now you're on 4 different eye drops 2 times a day, and you're having to put it in all the time. And as I mentioned, it's we're all getting older, and it's harder to even just manipulate sometimes to get it there. You can't see it when you try to get it in. So there's a lot of research actually being done for that, and there are certain implants that they're thinking about, like in the tear duct, even contact lenses, different devices that you could actually implant into the eye itself, things that can be injected into the back of the eye. So there's all these things being looked at to try to help reduce that burden of putting in eye drops all the time. So those are all being researched, but not really necessarily available yet. There's also new medications coming out, new eye drops coming out, there's new surgical techniques coming out.
Any new drops coming out?
There are actually, yeah. So look for that in the next probably 1 to 2 years.
And try to get your insurance company to pay for them.
Right.
Oh,
That's the other problem.
We're trying with Lumigen, don't worry.
Yeah, Lumigen.
That's,
Yeah.
What causes floaters in the eye?
So as I mentioned, that sort of, that gel that fills up the middle of the eyeball, we call it the vitreous gel. And over time, it undergoes some changes, and it starts to become a little bit more of a liquid. And we see little cells and proteins, sometimes little, they start to move around inside of that gel. So when you look around, that gel sort of lags behind and moves with your eye. So you'll see if you kind of look left, look right, you'll see it just move across really quick. Eventually that gel, it's attached to the retina when we're younger, but as we get older and it becomes more of a liquid, it eventually separates completely from the retina. And that'll cause us, usually that happens when we're older, but it'll cause us to see a big floater, maybe even a few flashes of light. But that's when you start to see the big floaters. So really, if it's a floater that you're seeing every now and then, we usually don't get concerned. Those are more the common types of floaters. But if it's all of a sudden you see brand new floaters or really big floaters or hundreds of them, or flashes of light going off that don't stop, or a shadow that covers part of your field of vision, if that happens, then you want to go see an eye doctor right away to make sure it's not something like a retinal tear or detachment. But yeah, the common ones, usually nothing to worry about.
How are the eyes kept open during surgery?
So we actually have a device that we put in that it's like a little metal thing that just keeps the eye open, actually.
The eyeball doesn't move?
So we, as I mentioned, usually patients are actually awake because we just use local anesthesia and a little bit of anesthetic. And, there's a microscope that we use to do the surgery that sits about this high above, the patient's eye. So we try to tell them to just look towards the light during the surgery, but while we're doing the surgery, we can actually sort of keep the eye where we need it to be. But also we can talk to the patient, so if they're moving their eyes around a lot, we can say, just try to look towards the light, try not to move. So it's sort of a team effort. Keep the eye still.
As far as vitamins to prevent worsening of macular degeneration, is there an alternative to a REDS 2? I know the REDS 2 has gelatin, I would prefer to have something without the gelatin.
The original AREDS formula vitamins are out there too, but I don't honestly know if they have gelatin or not in them. Yeah, I'm not sure.
But I was told that there would be a risk because of the high vitamin A.
Yeah, it all depends.
And they don't have the, I don't know.
Yeah. The contents are they're slightly different. They're based on the same study, which was sort of extended, and they sort of tweaked the formula of the vitamins a little bit. But yeah, the gelatin in the vitamins are not part of the study, so that's just an additive that the vitamin company added. So maybe look at the different brands and see, because the AREDS formula is not a brand. It's just a formula.
Most important vitamins. Which are the important vitamins?
So again, so the AREDS formula, it stands for Age-Related Eye Disease Study. And so they looked at a combination of things, so lutein, zeaxanthin, zinc, copper, a whole slew of different components, basically. So out of those, I don't know which one is the most important, because they looked at so many at once, but that combination was shown to be beneficial to reduce the risk about 20% from going from early dry type to severe dry or wet type. So, all of those components potentially are very important. So, anything else? Yes?
A few years ago, my mom had a procedure where they vacuumed her eyes. And he was like a little, it was almost like a vacuum. Do you know what that was that for cataracts?
It could have been, if you're thinking of, so that device I showed, we call it, it's phacoemulsification is the name of the technique, but it uses ultrasound and a vacuum. And so we sort of use the ultrasound to sort of grind the lens up, and then the vacuum sucks it out. So possibly that.
All right.
Most likely it was that.
Well, speaking of cataracts, I had thought until you said before, the current procedure is almost like being a barber shop, like next, and then like, you just have the laser zap the cataract away, but you're saying it's surgery.
Correct. So for people who do use the laser, which is sort of a newer thing, that laser, what it does is it sort of breaks up the lens a little bit and it makes an opening to get to the lens, but you still have to go into the eye to sort of remove the lens. So it is an actual surgery now.
The actual surgeon is actually working.
Say that again?
A surgeon is actually doing.
Oh, correct. Yeah. So it's not just you sit at a laser.
45 minutes is too fast for me.
Right. No, sometimes it only takes 10 minutes too. Very fast, potentially.
Take your time, take your time.
Right, exactly.
I was outside for a while, but I didn't hear you say anything about the rods and cones or anything like that.
Yeah, so we didn't really go into the photoreceptors too much in the retina, just because that's sort of beyond what we're talking about today. But that's just, that has to do with the different types of photoreceptors in the retina, which is that back nerve layer of the eye.
Right.
What would cause the eye color, the iris color of the eye to change? And what is the blue ring that you sometimes see around the iris?
So we'll start with the ring first. So the ring is actually not in the iris, it's actually on the cornea. So what happens is it's little cholesterol deposited in the edge of the cornea that usually causes sort of a grayish blue color. So it's not actually on the colored part of the eye, it's actually on the cornea, but it looks like it's on the colored part of the eye because you don't really see the clear cornea. So that's what causes that change in sort of the color of the eye, even though it's not really the colored part of the eye changing. But the colored part of the eye, the reason that it's different colors just has to do with how much melanin, which is sort of the pigment that causes all the coloration of all of our skin. And it's sort of how much melanin you have in the skin affects how the light's sort of absorbed and reflected and gives us that eye color. So blue eyes, they just have less melanin, and brown eyes, we have more. And so
the change from the dark to the light.
Yeah, so depends. So some people can have actual, atrophy, inflammation, other things which can cause the iris to become a lighter color. Usually that's more of due to some kind of problem, though. In babies, it's a little bit different. Babies can be born with, blue eyes and they get a little bit darker. That's just because their pigment, it hasn't really deposited all the way. So usually it's due to something going on. Also, that melanin, which gives our skin, the darker color. Sometimes that can increase if you have different conditions which can cause it to get darker, eyes to get darker. Yes?
Someone had lazy eye as a child and it wasn't corrected. Is there a way to correct it as an adult?
So, depends. So, we use the term lazy eye. It depends on what you mean by that. So some people refer to lazy eye meaning that the eye is sort of drifted off one way or the other. But, there's another condition that we call amblyopia, which means that the vision is actually weak in that eye. So once you get to somewhere between age, 10 to 13 or so, somewhere in that range when you're, a young teenager, if the vision is, no matter what the cause is, let's say one eye just turns out it's really nearsighted or farsighted or astigmatism, or let's say just your eyelid, they're born with some condition where the eyelid is covering up the eye. Whatever the cause may be, if one eye is not really in focus and the other eye is, or your brain's sort of focusing on one eye, if it's not corrected for whatever reason, or if the eye is just misaligned, if that vision is not corrected at a young age, unfortunately, even if we correct it, let's say it's just nearsightedness in one eye, even if you correct that when you're an adult, you can't get that vision back because your brain's sort of hardwired to know what the vision is at a young age, and then you can't get it back. So the key is, if you notice anything, that's why nowadays in schools they check the vision in children to try to catch that early. Or if you notice the misalignment, you should see an eye doctor to make sure it's not affecting the vision. That's a good question.
Is it more harmful for the eye to use a small screen many hours, let's say, a telephone as opposed to a laptop?
So it's not that it's going to harm your eyes necessarily, but you may find it uncomfortable. You want proper magnification. You don't want to be straining your eyes. It's going to cause the muscles up here to feel some strain. You may get a headache in the front if you're having to squint all the time. And that goes for whether it's up close, far away, whatever it may be. And there's a whole other theory about blue lighting that you get from our phones, tablets, all these things. And it's sort of up in the air how much and if at all that causes damage to your eyes. So whether it's looking at a book versus looking at a screen, some people say that, these like a Kindle is better than a tablet because the backlight, you don't get all that blue light emission. Or a book is better than looking at the computer all day because you don't get the blue light from that. Some people think the blue light messes with your sleep cycle. There's all kinds of theories out there about that. But as far as whether it's better on a phone versus a computer versus a tablet, not necessarily. But you want to be comfortable. You don't want to be squinting and straining. Otherwise, again, you're going to cause yourself headache. But it's not necessarily going to make your vision any worse. Yeah, at this stage.
Thank you so
Thank you,
much.
everybody.
Let's have a good hand.